So the purpose of the presentation today is not to educate you about osteoporosis, but to talk about the role of dairy foods. So I'm talking a little bit about assessment of bone first, because that you can understand the research studies that I will present on. And then I will present on milk interventions in children and in adults, and then a little bit also about bioactives such as whey protein and the effect that it could have on bone health. Now, it's very appropriate that I talk about dairy because dairy is the biggest industry for New Zealand. So what is osteoporosis? Disease of bone that leads to increased risk of fracture, and that is because the microarchitectural deterioration of the bone causes that there's an increase in the weakness of the bone, and so fracture is the end point. So the bone mineral density is reduced and the bone microarchitecture is disrupted, and the variety of the non-collagenous proteins is different. Now in this slide you can see on the right hand side a very severely osteoporotic hip, the femoral neck there, and on the left what the healthy femur should look like. Now the bones in the body that have a lot of this spongy or trabecular, what you call trabecular bone, are the ones where the osteoporotic fractures usually occur. Now this slide shows us the different kinds of fractures and the age-related fractures, but the difference between men and women. So on the left-hand side we have females and on the right males. And the three kinds of osteoporosis-related fractures are the hip fracture, which is the worst, of course, most detrimental and can cause mortality, the vertebral fracture, and the wrist fracture. Now, the wrist fracture is one of the first ones that start to appear maybe with severe osteoporosis, and you can see the purple dots, and it starts increasing incidence at the age of about 40, 45 in females. It doesn't have a very high prevalence in males, probably because the male skeleton is much denser. The second fracture, the vertebral fracture, starts to increase in occurrence after the age of about 49 in females, so around the time when menopause happens and females can develop osteoporosis. So after the age of 70, there's more a significant increase. Now in males, fractures occur at a much later stage. And for males, osteoporosis is an age-related disease. Of course, they hopefully don't go through menopause. And so the fractures are at a much later age. So between the age of 84, there's an increase in vertebral fractures. If we look at the incidence of the hip fractures, in females, it's after the age of 70, a very significant increase in the occurrence of those fractures. And in men, it's after the age of 80. So difference in the pattern, and those are the ones that we wanted, especially the hip fracture, that we're trying to prevent with intervention or with nutrition. I have to give you some little bit of bone physiology because we use markers which tell us what's happening on the bone level. So the skeleton has to be remodeled continuously throughout life because it has to maintain strong and resilient to fracture. And so there are little pockets of remodeling like this throughout the whole of the skeleton, all of our lives. And we call these bone remodeling units. These units contain the bone cells. The one is the osteoclast, the bone that resorbs bone. Little here you can see it's a multinucleated cell, and it secretes acid on the bottom and causes bone resorption. And the other cell is the osteoblast, or the bone building cell, that will put mineral back onto the bone and rebuild the bone. So the process of bone resorption is followed by bone formation, and the combined process is known as bone turnover, and these are closely linked. So what happens is some cytokine or some event causes that the activation of the osteoclast take place. This could be hormonal, it could be exercise by bending of the bone, it could be cytokines, it could be inflammation. And the bone cells start resorbing. And you can see bone resorption takes place in quite a short period of time, into 3 weeks. As the bone is being resorbed, some factors are released from the bone. There are macrophages that come in and clean up the bone where resorption has taken place. And then there are growth factors and probably more cytokines and hormones that can affect bone formation. And so from the pre-osteoblasts, the mature osteoblasts are being formed, and they cause bone formation. Much slower to rebuild the bone, 3 months' time. So it's quite a slow process. And therefore, if we want to monitor bone health using an intervention, we want to use bone density, such trials have to be quite long, up to 2 years or longer, to see any difference in bone density, and it's because the process is so slow. And so over the years, we've developed other methodologies in order to monitor bone. So how do we assess bone? Bone density, I'll talk about in a minute, but bone turnover markers. Now, these started to be developed in the early 90s. How would you judge whether bone is being built or resorbed? Old-fashioned way could look at urinary calcium. That's a very rough estimate. And of course, the body has hormones which really control mineral excretion. And so it's not really a good indicator whether you're having bone resorption. Many other things could happen and increase calcium release from calcium excretion in the kidneys. One can measure enzyme activities of the bone cells. Again, that's not mainstream. It's very expensive. It's not something that's done commonly, using specifically this marker for the osteoclast. But then, over the past 20 years, they've developed a number of these bone markers that can be measured either in the urine, the early measures were in the urine, or can be measured in the blood, which is an indicator of bone resorption or bone formation. And the most common, and the one that I use most of the time because it's very reliable, is called C-telopeptide of type 1 collagen. So it means it's pieces of collagen that's been released due to bone resorption, and we can measure it as an indicator of bone resorption in the blood. Of course, it has specific things. It has to be after fasting. It has to be at a certain time of the day because it has a circadian rhythm. So a lot of things on when and how to measure it, but it is still a very reliable measure. And so those are called biochemical markers. Now, of course, the gold standard, and you referred to body composition this morning, is the DEXA for body composition for bone density, and for the diagnosis of osteoporosis, the DEXA measurement, of course, is the gold standard. It can do the 2 regional scans, which are used, the spine or the hip, to diagnose. And it can also do body composition, which we talked about this morning. Now, of course, this would be the most reliable to do fat and lean percentage, but it correlates very well with the other methodologies. We have done studies like that with our students in New Zealand. This is what a DEXA look like. I have exactly that one in my lab. But then we don't have access to DEXA everywhere. It's very expensive, and it's costly actually to do the scans, and so a lot of people don't have access. And especially if we do field studies, we cannot take a DEXA with us. It weighs a ton. So we can use other machines to measure bone density. An example is this one, the one that can measure the bone density of the forearm. Now, in Northwest Province, we've been doing a study in the rural, in Geneesa, in that area, and we have taken one of these with us to do forearm bone densities as an indicator of bone health. And then a subgroup of the women was brought into Potchefstroom where we did bone density measurements. And so we have an equation now which we can use to relate forearm bone density to central bone density, and we estimate whether the women have osteoporosis or not. So it's not standardized in order to be a diagnostic instrument. The other one that's used around is ultrasound, where the women or men put their foot and they scan. It measures the speed of sound through the heel. Again, this is not a diagnostic machine. Sometimes they use it as a screening machine. The doctors, clinicians, when it started happening, called it shopping mall bone densitometry, because they very often put it in a pharmacy or in a shopping mall and say, go and put your foot in and we charge you money. Again, this is not a diagnostic instrument. We have done correlations in some of our studies. There's some correlation, what we find with the ultrasound machine versus DEXA, but it cannot be used to diagnose. We can monitor treatment, but it is not a diagnostic tool. So how do we regulate calcium homeostasis. Two other things that we can measure or go look at is parathyroid hormone and vitamin D. These two are the two hormones that are central to bone and calcium homeostasis. So PTH is secreted by the parathyroid gland, and it changes because of change of blood calcium in the blood. And so if there's a change, a drop in blood calcium, the parathyroid hormone is secreted, and it increases calcium release or bone resorption, so release of calcium from the bone. PTH also controls the amount of calcium that's excreted in the urine, and it helps in the kidney to change inactive vitamin D to calcitriol active vitamin D, which helps with the intestinal absorption of calcium. So these two hormones work very well together and to help maintain bone homeostasis. So we can use PTH, therefore, changes in PTH and the biochemical markers to assess what is happening around bone. We don't have to do a 2-year-long study to assess bone health. So PTH and biochemical markers can give us an indication. Again, the biochemical markers is not a diagnostic tool. It can be used to monitor treatment or response to nutrition, like calcium, for example. PTH and the biochemical markers are very often high with menopause, and they've shown that high turnover, which means high levels of the biochemical markers, is associated with low bone density. And the biochemical markers in PTH can also identify patients that will respond to various interventions. And they've shown in many studies that a change in CTX, that type 1 collagen release into the blood, changes in that and a reduction is associated with changes in BMD over time. So the PTH and the markers can predict bone loss and fracture risk. And so what they found is that although bone density is the gold standard, it alone cannot tell you whether a person is going to have a fracture or not. They have found that up to 50% of people who have fragility fractures actually had a normal bone density. So if they only had a bone density measurement, they would not have realized that they might have had an issue with bone health. And so they had normal BMD, but they still fractured, so which means there was something wrong with the microarchitectural structure of the bone. So bone strength depends both on bone mineral density and the quality, and therefore the bone markers might give you a better indication of bone quality. So bone remodeling, which we measure with the bone markers, is a determinant of bone strength. And so measuring bone markers can provide information about bone remodeling and bone strength independent of whether you have a normal bone mineral density or not. All right, let's move on to nutrition then and calcium. So these are just selected risk factors for osteoporosis, and I'm sure all of you are aware of them. Of course, the biggest determinant of our bone health is our genetic background. Then on top of that would be the various lifestyle factors such as our excessive alcohol use, smoking. We've heard a lot about smoking today. It's also bad for bone, not just your heart. Anorexia, excessive weight loss is not good for bone, or very low body weight. And then, of course, inactivity and bed rest, especially in the elderly. And there are a variety of nutritional factors as well that can be associated with poor bone health, which is a change in vitamin D status, and you'll have a talk about vitamin D soon. Low calcium diet, which affects bone health in terms of bone resorption. Excessive sodium, we heard about sodium yesterday, and again, sodium can affect bone and calcium excretion. Changes in vitamin K. Vitamin K has been known mostly for its blood clotting function, so not for bone health, but it has a very significant role to play in bone mineralization. And then low B6 and B12 and folate intake. So these are just some, not all, of the factors that could be associated as risk factors. So what influences our bone mass? And first of all, we'll talk about peak bone mass in a minute. So how much bone we actually accumulate in the first 2 decades of our lives, that's the biggest determinant of whether we are at risk of developing osteoporosis, and that's called peak bone mass. how much bone we lose in later years, so which means with menopause in females, and how healthy we are during and after menopause, and in men how healthy we are, will determine the rate of bone loss in later years. How long we live, of course, osteoporosis the incidence is getting worse because of the aging population, and then risk for falling. And all of these are contributed to by genetics, lifestyle, disease, endocrine disease, our reproductive history in females, and of course, diet. Factors that we can change is nutrition. We can change all of these others, but we just want to focus now on the role of calcium nutrition. Of course, calcium is the most important and essential for bone. This little cartoon just shows you calcium absorption. Calcium is utilized not only by it's stored in the skeleton, and it's used throughout the body for cardiovascular function and for other functions, for the nervous system as well. But most of the calcium is stored in the skeleton. And so the skeleton is the source of calcium to provide or put back as our hormones change or our calcium nutrition changes. And then calcium excreted in the urine, and a large amount of calcium is excreted in the feces. Now this slide is just a cartoon-like slide. It shows changes in calcium, how changes in calcium intake can affect bone mass. This is a rough graph that shows you the attainment of peak bone mass around the age of about 18. At the end of adolescence, a person should have 80 to 90% of the adult skeleton. Then there's a little bit more bone gain after that, bone is sort of stable, and then, of course, with menopause in females, there's a significant loss of bone, which could result or put them into the area where they are at risk of osteoporosis. So the bottom line is for females, and the top line is for males with inadequate calcium nutrition. And the dotted lines now show you what the effect of adequate calcium nutrition would be. So just having good calcium nutrition can make a big difference in the attainment of peak bone mass, and also reducing the risk. You can see the line is much lower when it goes into the area where a person is at risk of osteoporosis. So therefore, lifelong reducing the risk of developing osteoporosis. So what is peak bone mass? In a baby or neonate is about 100 grams, and the total adult skeleton is about 3 kilograms. So the optimal peak bone mass is attained in the first 2 decades, 90% by the age of 18, and the maximum about at the age of 30. There's still dispute about that because that depends on environmental factors and also genetics and ethnicity, of course. And so the most peak bone mass is the most important predictor of bone mineral content in later life. And so gradual loss of bone mineral content occurs in men and women once peak bone mass has been achieved, and of course then more rapidly in females with menopause. This is just a graph from one of Rizzoli's papers showing the difference in bone loss and the risk of osteoporosis. So the dotted line, this person has reached 110% of mean peak bone mass. So a higher peak bone mass at the age of 25, bone loss with life and then with menopause, and again a delay before this person would be at risk of developing osteoporosis. But an inadequate peak bone mass over time, bone loss due to menopause, and a much higher risk of developing osteoporosis. So it's quite a significant determinant factor. Then, of course, vitamin D, which we'll hear about later. Vitamin D is central for bone mass. Now, it has a lot of other functions, but for bone, it is essential. Insufficiency causes reduced calcium absorption because it is necessary for intestinal calcium absorption. It changes ionized calcium. Insufficiency causes a rise in PTH, which causes bone resorption. And the recommendation, and it's also different between different countries, can range between 5 to 15 up to 20. Right, if we go to dairy and bone health. First of all, I just touch on children and then on adults. Now, there's been studies that show that infant milk feeding influences adult bone health. And in prepubertal children with low milk intake, they are more prone to fractures. Now, this work was done by Elsa Golding. She lives almost at the south point of New Zealand in Dunedin, which I say is the closest place to the South Pole, because it's very cold there too. Now, she's done years and years of work in children and adolescents, and she's looked at inactivity, and she's looked at obesity, and she's looked at milk intake. And in obese children, she's shown that they're more prone to forearm fractures, and she's also shown that children, prepubertal children with low milk intake, are prone to fractures, 2.7-fold higher. In some studies, they've shown, although this is still disputable, that milk consumption is associated with increased body height, so children growing taller. But milk is complex, so milk provides calcium and phosphorus, but many other bioactives, and some of the good effects of milk and dairy, therefore, could be not just the calcium and the phosphorus that are present, but because of bioactives, which I will touch on a little bit later. And so there's consistent evidence that long-term milk avoidance is associated with smaller body height and lower bone density. Now, this is just an example of studies which Rosali summarized in prepubertal and early pubertal children. Milk interventions. Now, if you look at these, the mean age where all of these studies are done is between the age of 10 to 12, and it seems to me that is the age where milk nutrition can make quite a big difference. One study was done at the age of 16. Megan Merrily, she did that in Christchurch. Don't know why she chose 16, but she didn't have good effects because the kids didn't want to drink the milk at that age anymore. They didn't want to be supplemented with 2 glasses of milk per day. The others were younger, and you can see most of them measured whole body, so using DEXA, using whole body calcium content, and had some significant increases, especially this study, Chan et al., probably in Asian kids, significant changes from compared to the control, whole body increases. And in Zhu et al., milk, only 435 milligrams, had significant change in bone there in the forearm. So milk has a significant effect, and the interesting thing that they've shown, and Jean-Philippe Bonjour showed that milk has a lasting effect. So in his studies, where he supplemented adolescent young girls, he maybe supplemented them for a year, and then stopped, and then measured bone density a year later, and the good effect stayed. So milk has a long-term effect on bone that stays and improves growth and mineralization. So in adults, the US report, Dietary Advisory Committee reports that 7 out of 7 randomized controlled trials and 25 out of 32 observational studies report significant positive association between dairy foods and bone density. And 5 out of 8 studies found dairy significantly associated with reduced fracture risk, and 3 reported no effect. And in Spain, in a study that included over 5,000 women over 65 years of age, intake of dairy calcium of less than 250 milligrams was independently associated with risk of fracture. And the K-Enhance, which is run in Korea, study of 700 men and women, dairy was associated with significantly reduced risk of functional disability in men. Now, Jean-Philippe Bonjour is the person I just talked to that did quite a lot of studies in adolescents. He did some studies in older adults as well, but not with milk intervention. In these, he used a soft cheese, like a cream cheese. And in the top study, he had 2 groups, a control and a treated group. And so he gave them vitamin D calcium fortified white cheese, which provided 400 milligrams of calcium, small amount of vitamin D and protein over 6 weeks, and that reduced bone resorption. Now, how does he know that? If you look on the graph on the right, he's used the bone biomarkers. He didn't measure, you can't measure bone density after 6 weeks because it's much too short to show anything. But this is the gray bar is the control group, the black bar is the treated group, and this is C-telepeptide of type 1 collagen, the bone marker that shows us resorption of collarbone collagen. And there was a reduction because of the consumption. TRAP5B is a marker of the osteoclast, and you can also see significant reduction in the activity of this enzyme, so reduction in probably in the number activity of the osteoclasts. And interesting, which happens quite often with milk interventions, an increase in IGF-1, insulin-like growth factor 1, even in these older women. So this is control, and that is the intervention group. The bottom study was done in elderly women. Here he did not have a control group. He compared themselves to the baseline. Again, he fortified them with a soft white cheese, providing 300 milligrams of calcium, vitamin D, and protein over 4 weeks, so a very short period of time. And in these elderly women who were over 80 years, he still had significant effects. If you look at the graph, significant change in vitamin D status, significant reduction in parathyroid hormone, which means he reduced bone resorption, significant reduction in CTX, a bone resorption marker, reduction in the activity of the osteoclast measured by TRAP, and again an increase in IGF-1, interesting in these elderly women, which could indicate that this intervention could have a positive effect on bone. This is another study by Bonjour where he treated women, gave women milk. They had baseline diet of that already contained 600 milligrams of calcium, and he gave them extra milk. And the extra milk on top of the already high calcium still had a significant effect in reducing bone resorption as measured with PTH and CTX. So calcium is quite powerful. You know, I always say it's probably the most powerful thing in terms of bone. Just some data of one of my own studies, which we did in Beijing, where we supplemented postmenopausal women with calcium-fortified milk, providing 900 milligrams of calcium and 6 micrograms of vitamin D. And this was for 12 weeks. And this short study, and only the 6 micrograms of vitamin D had a significant effect on vitamin D status, and that is probably because their status was not very good. So most of the women, if you look on the left, micromoles per liter, the published IOM cutoff for vitamin D sufficiency is still published as 50, although bone people and everybody else is shifting it up to 70 or 80. It's the normal vitamin D. Most of these, the mean was between 30 and 36, so they had very poor vitamin D status. And the 6 microgram improved their vitamin D status significantly over the 12 weeks. The bar graph shows the women with sufficient in the control group, insufficient and deficient in vitamin D. And with the control group, it stayed the same, but the milk intervention with a small amount of vitamin D reduced the number of women with vitamin D deficiency. It was raised into women that are vitamin D insufficient, and more of them became sufficient in vitamin D. So only a small amount of vitamin D had quite a significant effect. And again, that also affected bone turnover and bone resorption. So PTH, over the 4 weeks, significant reduction in PTH and a significant reduction in bone resorption marker, CTX. So in this study, we showed these women had a very low calcium intake. So their dietary calcium intake was less than 500 milligrams per day, which is high for Asian diets. Other studies that I've done shown in Indonesia and in Philippines that the calcium intake is between 200 and 300 milligrams per day, together with a very poor vitamin D status. More than 90% of the women were vitamin D insufficient, and their bone markers, CTX, was up in the level of 0.5, which indicates high bone turnover, high bone resorption, and PTH was quite high. And the intervention reduced body weight. Yes, they lost weight with high calcium intake, which is one of the theories of calcium controlling body adiposity. Changed the reduced body mass index, and we improved vitamin D status and reduced bone resorption. If we touch on bioactives, now you are all familiar with whey components because whey protein is used in infant formula as far as I understand. Now whey is also a big side product for the dairy industry, and Fonterra, our dairy industry, makes a lot of money off selling whey protein to put into protein powders for the bodybuilders, not just for exercise recovery. So it's quite expensive, but they're also trying to find other benefits for whey protein. Now, there are a whole swag of them that are present in whey, and it depends on whether whey came from milk, which kind of cheese was being made or not. And some of the whey protein components have been looked at in terms of bone health. Lactoferrin is sometimes used in infant formula. Alpha-lactalbumin is there, and then there are other mycoproteins, and we've done some work on acidic and basic fractions. So in trying to find new ingredients that actually can affect bone, not just whole milk. Study done in Perth by Richard Prince, where he supplemented women with 30 grams of whey protein on top of their normal diet as a drink. No effect on bone, only an increase in IGF-1, which could indicate that there was an effect on bone formation. Using the same whey protein in an animal study by Connie Weaver in the States, the whey protein improved calcium absorption and raised femur calcium, but chronic feeding over 8 weeks had no effect on bone density. Milk basic protein, this is a very busy slide, but of course they've done such a lot of work. There's a dairy company in Japan called Snow, and they have milk basic protein, MBP. And they've been working on this for the past 15 years, and they have it on the market as an ingredient, 40 milligrams a day, that can improve bone density. Now, some of these studies are a bit dodgy, because they do say that they have been improved by BMD in 6 months' time. And there you can see as well, in 6 months' time. And that's really quite a short period of time. So I'm not sure whether that is true or not. But it is out there. Some studies, in this study in China, showed no effect, and some of them were positive. A whole set of in vitro as well as in vivo studies supporting that. My own work, acidic and protein fractions from whey, done where I am. We did 2 lots of studies looking at various acidic protein fractions from whey. Now these are rat studies, so it's not human bone that I'm breaking there. So what we showed in the first one is that the acidic whey fraction showed slowed bone loss due to ovarectomy in the mature female rat. What we mean by that is the FDA-approved model to test drugs or nutrients for osteoporosis is to use the ovarectomized female rat. So the rat is sham operated, which means she gets incisions, but the ovaries are not removed, or the ovarectomized rat where the ovaries are removed and she becomes postmenopausal, and she becomes round and fat and she eats a lot. So in these studies we showed, so after ovarectomy, we fed them with these whey fractions, and you can see that one of the fractions is raising bone density even after ovarectomy back towards the sham levels, indicating that there might be a significant effect. But we also show bone density, and we do also bone biomechanics. So we use this machine, which is a food texture analyzer, which they use in food chemistry and with fruit, tomatoes, whatever, to look at firmness of fruit. We use that, and we can break the little rat bone, and we can look at how strong the bones are. And then in a second study, we used the rats again, and we used mineral acid, WPC, so various sources of whey protein, and again looked how it affected bone health. So there's the rat getting a bone density, she's sleeping. And so we can do serial measures. And in these animals, again using the ovarectomized rat, there's your sham whose ovaries were not removed, the OVX rat, whose ovaries were removed, so she's postmenopausal, and the effect of the fractions. And you can see that over time, this is significant. This is quite scary if you see how quickly bone is lost with the loss of estrogen due to ovarectomy or menopause. Bone slowing down, and then the one that has an effect there, starting to raise bone density back to normal. So these fractions were patented, but they're so expensive that we actually can't put them into any product. So I'm not sure where we're going with that. Then we use cell culture to assess other bioactives. This just shows you the osteoblast cells in vitro. And if we use mouse macrophages, we can generate an osteoclast. This is what an osteoclast looks like in cell culture. So it becomes a large pink cell. And we do this work here at physiology at UP as well. So we use those models to assess the effects of bioactives. And this is lactoferrin, which is present in infant formula in some places. It is an iron-binding glycoprotein which occurs in the milk of all mammals. And what we've shown is that lactoferrin improves bone formation, so the graph on the right. This is different concentrations, increasing the growth of the cell, so it has some anabolic effect. And then we looked at the osteoclast cells, and it looks if it reduces the number and the activity of the osteoclast. So which means lactoferrin as such could have an anabolic effect on bone, and it can also reduce bone loss. One of my colleagues in Auckland, Jill Cornish, did study on mice, and this is called local injection. So what they do, the poor little mouse gets an injection of the protein on the skull, and it increases bone formation. So they do sections. So this is the control. And the mouse who had a small amount of lactoferrin injected in the skull bone increased bone formation. So this is the amount of bone formation. And then rats with gavaged, that were orally gavaged, also reduced bone loss. Now, unfortunately, lactoferrin has been tested in humans. It's a very large molecule, so it's still doubtful where it's actually being absorbed, and the human studies showed no positive effects. And I thought of just, because you're dietitians, to stop and finish this talk with a comment on calcium supplementation and heart disease. Because another one of my colleagues in New Zealand, Professor Ian Reid at University of Auckland, has since 2010 published a whole swag of papers in which they have done, as the group have done, retrospective analysis of the WHI, the Women Health Initiative study that was run in the States, and several calcium supplementation studies. And they come up with a theory that calcium salt calcium supplementation can increase the risk for developing myocardial infarction and stroke. Now, since 2010, there has been quite a lot of papers contradicting this or talking with him, and it's still not sorted out. The papers are still being published. Now, of course, there's not been any intervention studies. These are retrospective analysis and associations, no intervention. So whether it's true or not, we still don't know. The theory behind this, that increase in ionic, so the free calcium levels in the blood, could increase plaque thickness, could increase aortic calcification, could increase the increase in heart disease and stroke, and increase mortality. And a lot of these people have published in this area. But in 2012, last year, I had postgrad students do an assignment on this, and there are just as many studies now against this whole theory than is saying that it is true or it is true. So it is still out there and being discussed. And so this graph shows what calcium, if a person would take a dose of calcium over time. So this is serum ionic calcium. Over a period of time, serial blood samples with calcium carbonate and calcium citrate, significant increase in blood calcium over a short period of time, and it tapers down again. And this is the theory that they have, is that the spike in calcium is so large that the body cannot do much with it. The PTH response, excretion in urine is not fast enough, and there is a possibility that the calcium could get trapped somewhere in the tissues. Now, we tested that in my lab. Beautiful graphs, aren't they? And so this shows what we wanted to look actually originally when we planned the studies, just to look at the dose response in milk, so calcium in milk, the response of serum calcium, and the bottom line will be 250, that was normal milk, 500 milligrams in milk or 1,000 milligrams in milk. And you can see a nice graded response in the blood calcium due to the dose of calcium that we are giving. On the right-hand side, this is the effect of calcium salt and calcium in milk. So you can see with a calcium salt, the ionic calcium spike is much faster and higher than the calcium in the milk. And this shows that calcium provided with food or in a food matrix is slower absorbed and probably does not pose the risk, the so-called risk that they say there is, because of this highly significant flux in calcium because of a calcium salt supplementation. Now, if you look at the bone resorption response, PTH, there's no difference. There's a difference between the 250 milligrams of calcium and the 500 and 1,000, but no difference in the response of the body between 500 and 1,000. So which means there's a threshold where the body is not responding anymore, and taking more calcium is not always good. And also in this one, with a spike with a calcium salt, the response is exactly the same. So it's just in the absorption that the absorption from the calcium salt supplementation is very fast, causing a spike in ionic calcium. So what we've shown here is that the serum and ionized calcium to a gram of calcium salt and calcium in milk is different. So similar levels are reached over a long period of time when the dose is delivered in milk. And it also supports the notion that the absorption pattern of the calcium intakes that indicates that fortified milk might be a safer matrix for delivering large doses of calcium without really upsetting the calcium homeostasis. Now, because of all these publications, because it came out of New Zealand, the GPs in New Zealand do not prescribe calcium routinely anymore with osteoporosis treatment. The recommendation is to rather to try to get your daily calcium from food and not supplements, if possible. It's not always possible in all people. Right, to summarize, major factors during childhood and adolescence may affect the ability to achieve peak bone mass, and one is nutrition. The greatest amount of dietary calcium is obtained from dairy foods, which also contribute potassium, magnesium, and the bioactives. And the bioactives may play an essential role. So the basic acidic fractions from milk, the lactoferrin we talked about, and work that I've not shown you, there are fractions from colostrum also that we're working on. So in older adults, though calcium will not prevent bone loss due to other factors, not to menopause, calcium cannot counteract the effect of loss of estrogen, it stays essential to bone. Milk and dairy foods are bioavailable and good sources. And according to Lotters, up to 2,000 plus hip fractures per year may be prevented by inclusion of dairy foods in the diet. I thank you for your attention.